My name is Jimmy Sherman. I'm a clinical manager at Boston Medical Center. I run a small outpatient satellite clinic in Winthrop. And we at Boston Medical Center made a virtual health committee at the beginning of the COVID crisis to figure out how we were going to continue to deliver high quality care with the resources we were given. Um, so it was kind of a free for all at first, which is why we decided we needed to have a committee to kind of streamline things. Um, we were using WhatsApp, we were using FaceTime, we were using Zoom, Skype, whatever video platform we had, we were trying to use it just to get our patients in. And we quickly realized we needed to streamline. So we formed a virtual committee. Um, You'll see all the names here. It's a good portion of our clinicians. Lots of experience, some OTs, some PTs. All of our management was involved, as well as some of our front desk team as well. So it was really a big team approach to kind of figure out how we were gonna handle this epidemic within within our own department. Um, Here's kind of the agenda today. First, we did a survey to figure out what was going well, what was not, and we worked to streamline that. Um, the exam, how to do an exam with telehealth, how do you establish a plan of care, and then the fourth one is kind of for the front desk, like how are we triaging these patients? How does the front desk know what's appropriate for telehealth, what's appropriate to come in person, and then finally a couple resources that we've made for our department. So the clinician survey was a really great tool that one of our therapists made. She just made a survey monkey, and we got 41 of our 31 of our 41 clinicians to respond. And we were able to identify problem areas, gaps in care, and then we came up with clear action items of what we could do with the data from the survey. Um, there's some really great overwhelmingly positive feedback from the staff. You can see some of the quotes there. I don't need to read them, but it's surprisingly positive response based on what was going on around everyone. People were really happy to continue to be able to give care. People were really happy that they didn't have to see patients at a time when we didn't know a lot about this disease. So it was a really great experience, I think, in hindsight, going through all of this. Some of the things we found from the survey, patient comprehension. So I should mention that we finalized on Zoom for most of the COVID pandemic. I'll get to another thing later where we actually have recently changed platforms, but we've used Zoom for 90% of it. And these are some of the issues you can see: patient comprehension. The patients don't have things at home. There's less clinical collaboration, which is something that many therapists thrive off of: seeing other people do exercises, seeing other people do manual treatment, and kind of having that clinical conversation. With telehealth, you're very much in your little silo, you're in your little computer, and you're not seeing what other people are doing. So that lack of collaboration was something that was felt. Our documentation, this is specific to Boston Medical Center, our documentation system did not merge well with how we used to do it in Epic. Workstation ergonomics, audio quality. You can see we got these nice little headsets. So a lot of improvements that were identified and quickly changed. Ergonomics was a big one. No, we're not used to doing this. We're not used to sitting at computers and looking at screens. We are physical people. We are up, we're on our feet, we're working with our hands. So we quickly realized our work sites were not set up for this. So we made a lot of changes. We got some better chairs, headsets, cameras, lots of things to help uh, just make it better, more ergonomically sound. We actually brought in, this is kind of funny, we brought in our occupational health people at the hospital, and they were kind of like looking at us like, why are we here? You guys are the expert on this stuff. So they did give us a couple pointers and tips, but it was nothing that we didn't already know. We just kind of wanted to go through the bases and make sure we weren't missing anything. So some ergonomic stuff, like I said before: chairs, footstools, wrist supports. We moved a lot of monitors around. We have high-low wows that we got. So you can use it sitting, you can use it standing, you can move it around. Headsets, clipboards. Our ops manager got us about 50 of these headsets. So they're at every computer now in our department, and they're really great. They're somewhat noise canceling, so you can hear the patient very well, and it just makes it better for the communication and for the audio. We still obviously have some ongoing barriers. We did get a couple WOWs. That's a workstation on wheels, if you're not familiar with that acronym. But we can only get so many of those, and they also only so many of them fit in our little clinical areas. But people love the WOWs. They're on them half the day before they go to lunch or after they come back from lunch, just cruising around on that thing. And they can both treat a patient in person, or they can then turn around and then use that same WOW as a telehealth machine. And then also certain physical structural limitations to the buildings that we couldn't really change. But we did make a lot of great improvements that were received very well by the staff. We've also looked at virtual rooming. It's kind of a work in progress. A lot of the other departments at Boston Medical Center use the MA, the medical assistant, to call the patient or jump in the room ahead of time and let the patient know, or take the history from the patient. A lot of doctors' offices will use an MA. In old life, they would take your vitals, take your weight, ask a couple questions. Now they're using the MAs to do actual like tech checks to make sure they can get in, make sure their audio is good before the doctor comes and joins the room. We're working on that as a way to tell the patient if the therapist is running late, or we do have some issues still with patients logging on correctly. So we're hoping to use a co-op student, which all of our clinics have year round, to try and figure out how we can use them to streamline the getting in the room process. So as I hinted at earlier, about a month, maybe 6 weeks ago, we just changed to a brand new platform. It's called Visuwell. It's completely replaced Zoom. There's been some pros and cons to it. A lot of the cons are more just figuring out a new system. It's not application based, so the patient doesn't have to download anything. It's web browser based. So they just get a link, a text message sent to them about an hour before their appointment, and they just click the link, and fingers crossed, if everything works the way it should, you and the patient are both just joined into the room instantaneously. It has all the same features that you know and love in Zoom. You can share screens, you can add someone else if you want to add an interpreter. You can do a whole lot of things. It's pretty comparable to Zoom, except that there's just not, it's web browser based instead of application based. So it's been going well so far. Definitely some headaches, but nothing worse than what we were dealing with in a year ago in March and April, when we were figuring out how to get all of our patients seen via telehealth. Moving on to examination. So to sum up the clinician survey, I think I said it before. We did a lot of great things to really help all of our clinicians optimize whatever they could using Zoom or Visuwell. So onto the examination. This is something that a lot of clinicians realize. I don't know how to test balance over a Zoom. I don't know how to test strength over a Zoom. So this is a big area where we tried to figure out how we could best help our clinicians. So we kind of use this as almost like we crowdsourced it. How are you doing this? How is this therapist doing this? What works well for you? So we created kind of a tip sheet of how we could recreate certain tests, how you could recreate certain outcome measures, because it was brand new, and now it seems commonplace, but it was brand new just a year ago. There's an article that we cited here that we get 70 to 80% of our diagnosis just from the subjective part of the exam. So, we're really only missing, if you can believe that, 20 to 30% from the tests and measures that we do. So we really can still do a lot of what we need to do on the evaluation, and then throw in a couple of these tip sheets. And I feel like we can get us to 90, 95% of what you could do for most patients in a telehealth examination. We have all this stuff set up in a local drive on our computers so that everybody can access this. This is what the tip sheet looks like. This is very condensed. Each of these, the neck, the thoracic, the lumbar, all those are shrunk just so you could get an idea. But there's one section you could zoom to any or click on any section, and you have tons of tests, tons of impairments that you can sort by impairment, you can sort by test, and it gives you an idea of how you can try to do this test without a hands-on assessment. So establishing the plan of care was definitely a big area for us because, as I've said before, this was very new. Is a patient appropriate for telehealth? Are they appropriate for hybrid? Are they appropriate for only in person? So we had to kind of streamline and come up with a real kind of approach for all of our therapists that they could follow to make sure they were doing right by their patients and they were following their plan of care. So we kind of took a good look at documentation. These are actual things that we've cut and paste from our documents to show what's a good assessment, what's a bad assessment. I'm not going to go through this. We all know what good and bad is, but we really want to call out: is this an in-person? Is this hybrid? Here's a bad one. They're sparse. They're not showing any kind of functional limitation, and they barely call out: is this a hybrid? Will this be in person? Will this be strictly telehealth? So establishing this plan of care was important, and I will show you kind of a schematic in a couple slides that we developed to help our therapists really know what they should be doing if it wasn't clearly obvious to them. We looked into a couple functional outcome measures in virtual health. There are a surprising amount of them out there. We didn't, you require purchase, so we didn't purchase any of them yet. But we did look at a lot of them for in the future, because we do believe telehealth is here to stay, at least in some capacity. So we do have this research kind of already done for us if we do decide to move on it in the near future. So Triage, this is kind of for the front desk, but also, as I mentioned just a second ago, helping to establish a plan of care for: is this person going to be in person? Is this patient going to be telehealth, or is it going to be a hybrid? So just kind of, this is a very high level look at what the front desk looks at. They just look at the diagnosis, what kind of bucket does it fall into, and these are preferred telehealth diagnoses. So the front desk can just look at this without doing a chart review. They don't need to have a clinical mind. They can look at the diagnosis and kind of filter it into an in-person patient or a telehealth patient. And we broke this down for PT, for OT, and then we have a similar one for preferred in-person diagnoses. So you can see the more acute things are here: the post-ops, acute strokes, and a lot of the pediatrics we determined would be better in person. And then we did the same thing for OT down there. So this is one of the triage kind of trees, the schematic that one of our OTs came up with. I'm not going to get into it due to lack of time, but you can follow it, and you can follow down, is this person progressing? Yes or no? And then you can follow the arrows and decide, does this person need to come in the clinic? Maybe they're not making progress for 2 weeks. Okay, let's get this person in clinic and see if we can jumpstart their care, and then they can go back to telehealth. Kind of looking for plateaus in their care, and then that would kind of be a cue to bring them in person. This is a kind of a more robust one for the neuro population in OT. But it's the same exact thought process. It's just, are they making progress with telehealth? Good, keep them with telehealth. Are they plateauing? No, let's bring them into clinic for a couple of visits, maybe do the re-eval in clinic, and then get them back to telehealth and just monitor their progress. But as you see, most of these things at the bottom here do end up in a hybrid model, which is kind of our preferred model. So that, and here are some resources that we use. No need to look at those, but that in a nutshell is how at Boston Medical Center we kind of took what was given to us and made the most of it. We involved our clinicians, we involved our front desk, and everybody, I think, both from a clinical standpoint and a job perspective, job satisfaction perspective, is pretty happy with a lot of the telehealth care that we provide. And I would have to say our patients agree as well. So thank you for your time. And if there's any questions, I'm sure I'll be standing by to answer them. Thank you.